Thanks, Adam. And thank you for the invitation. Excuse me. So, first, I apologize I didn't put my disclosure slide on here. I have no disclosures related to this, although I'm no longer doing research cases for one of the companies, which I'll mention as I go along. But why does this even matter? Why does this exist? We have all these great images now with X-ray. We have digital zoom. We use less X-rays and less gray in that way. But it's still, if comparing to other conventional radiography, invasive CTs, doing thoracoabdominal aneurysm repairs still comes with a high effective dose. And this is reported both in the lay papers, and then also has been reported out. And these are just some few examples in the literature. We've kind of known for a long time, even going back to Thomas Edison, how bad these X-rays can be for you. He used to experiment on his assistant's hands and rendered them useless. So therefore, he figured out to be afraid of them. There are a lot of anecdotal stories, but two I wanted to mention for sure. So this is Ted Dietrich, who trained with Dr. DeBakey and Dr. Crawford in Houston, went out to Arizona, started Arizona Heart, and sadly died some years back of a brain cancer. And then this is Roy Greenberg on the right, who was my partner for only a short year, but is a friend of a lot of people in the room. And know him pretty well, and really, one of the pioneers of all these things that we talked about today. And he sadly died at 47 years old of a peritoneal cancer, a peritoneal appendiceal cancer. Not sure that it was related to X-ray, but a lot of people surmise. So thank you, Dr. Park, for mentioning cydar Medical. And this is sort of a combination of the AI that he was talking about and 3D image fusion and overlay. It's a cloud-based system. And I think what their goal, obviously they fuse it with the 2D X-ray and to give guidance during the operation, but also during the planning of the operation. So I think it's trying to sort of bring up at certain centers that may not do as many or want to gain more expertise, or having that almost like a consultant there for you. I don't know if they'll ever sort of reach that goal or if it's a good goal at all, but that's kind of what their goal and what they want to do. It reminds me of visiting a few years back the old Vascular plant, and someone who was on the tour raised their hand and said, can I just give you guys, can I just have a program where I stick a CD in and it just tells me what to do? And that is what I think they're striving for here, but I have to be honest and say that I have not used it and I have very minimal experience with it. There is an ongoing trial right now in the UK, and where they want to look at 340 patients in 10 hospitals, and they'll look at things at OR time, anesthesia time, fluoro time, dose, contrast dose. So it'll be interesting to see the results of that when they are published. This system I actually have a little bit of personal hands-on experience with. We were part of the safety study in my prior job, which was really just consisted of putting the catheters in and seeing how they work. So this is IOPS, which stands for Intraoperative Positioning System. It's by Centerline Biomedical. It was a startup company that spun out of Cleveland Clinic. And it uses 3D with a GPS-style sort of surgical navigation to reduce radiation exposure. And it's funny on their website, they say to improve, very definitively it improves outcomes. That remains to be seen. But these are the components and sort of how it's set up. It's a little bit of a bulky system. And I can tell you from experience, this pad and this number 4, this electromagnetic tracking field, when you're trying to check what you want to do with the C-arm through this, it's really an impediment to actually seeing the patient. So at least the way it stands now, it's very rudimentary. It actually impairs your ability to see with X-ray, but they're still working out the kinks. This is what it looks like in sort of in a real-life hybrid room. So it's not too difficult to set up. The study people would come in, the night before, and they could set it up the morning of. It's not a big deal. These are the catheters and wires they have. They only have 8 French. They're also, we were playing around with them when we needed to try to with a steamer and try to make them into different curves and stuff. You could argue the sterility of doing that, but we did. But these are all they have, just simple catheters and one simple reverse curve catheter. This is a CAT scan, as you can see, and the focus here was on that if I can bring it back, sorry, on that right renal that kind of comes off anteriorly and bends around. So you would need like a 50 LAO to get that distal right renal. This kind of helps you do it, and you can see it almost looks like, an old Atari game or something. It doesn't look like a PS5, but this white part here is the tip of the wire, and it loses itself sometimes. And you can see that jumping around with position, but this is basically what it looks like and what you're working with when you do this. And this is just another video of a similar thing. So the idea is great. The idea is there. This was actually, like I mentioned, it spun out of the clinic, started by Roy, carried forward by Matt and a lot of people out of a labor of love. And I don't mean to denigrate it because that's where it comes from, but it still has a little bit of ways to go. And then this was another case actually from the clinic with mesenteric stenting. So it kind of came from using a standard wire, so you just see, use the IOPS wire, so you see that white part of the wire, but you don't see the catheter because we were using a standard catheter. And this again, which we can spare you. I added this one into the talk because I have no experience with this one, but from what I can tell, it seems a little more ready for prime time. And I don't know, I actually should have asked, does anybody have this in their institution? No. Or any of these? Was he using it for it? Yeah. So, and I know Andy Shanzer, I have to thank him as well. He provided some of these slides I'll show here. He's really done a lot of work with this at UMass. But this is another 3D device guidance. This is by the company Philips. This does it in a completely different way, though. It actually basically puts light, has optical fibers and basically puts light through them, laser light, and then analyzes how it's reflected back, and then that shows how all your catheters and wires are deformed and things like that. So it's a little bit of a different technology, and I think because of that, it's probably just a little bit further along. But again, it's these kind of systems. It can integrate pretty easily into a Philips system, as you can see here, because it's their own. And these are what their guide wires look like. They have a Burn, they have a Cobra, they have a regular guide wire. You can also use just this is just what they call catheter agnostic, but it's just any regular catheter, and you can hook it up to the lure connectors on this hub, and you can use any one of those as well. So it's a little more adaptable. I won't bore you with a long video here, but I just want to show you, what it kind of looks like in real life, how they hook it up. This is Dr. Krobel in Hamburg, who is one of the lead investigators as well, and has done a bunch of cases with this in Germany. And so you see how, and if you do have a Siemens machine or a Philips machine that can give you those markers with a pre-spin, that can get integrated into that as well. And here he's fixing a type 1 endoleak from a prior endograft. And then you can see, you can look at in two views at the same time. And yeah, it has a much nicer, at least a little further along with the technology, and with the, I wouldn't say ergonomics, but at least the appearance of it. And can you advance that slide? Because it just wants to give me the click on the video. Thank you. So these are just a couple more of the same thing, but I think it's kind of nice. You can, if you see in the upper right, you can have both your markers in one dimension, but also see with a 3D view of the aorta, your wire going down there. So you can see it's pretty nice views once you get it all set up the right way. So this has been studied a little more. You could see cydars in a sort of initial studies. Centerline is in the safety studies, and this has been studied quite a bit more, and is just a more advanced technology at this point. And thanks to our own Dr. Hahn, who can explain very complex things to idiots like me with slides like this. We appreciate those very much. This just shows some numbers behind their radiation reduction. It was recently published in JVS in January of 2023. One last potential use out there for FORS would be to actually embed these markers within the endografts themselves. So now you'd have that would be tracked as well as the aorta itself, and maybe that's something coming down the line. But of course, they'd have to work with endograft companies to do that, and probably make them that much more expensive. But they would be registered. So, we've kind of seen this aortic endovascular revolution. And if you think about in 1992, when Dr. Perotti's papers were rejected from JVS, people thought it was just a crazy idea. Now I think we're going through an endovascular image-guided revolution, and people might think it's crazy, but could we do a whole endovascular repair of an aorta without any radiation? Maybe. It would be nice if we could. Thanks.